first of all, thank you very much to my hosts for calling me over. I tell my friends this is I've had many friends in Patna and Bihar, but I haven't visited Bihar at all over 30, 40, 50 years that I've been in India or elsewhere. This is really my second visit, and I'm really pleased to be here. The good part is that Jeff has done the hard work for me, because I'm coming at this issue of health coverage from a different side, from the macro side, taking the goal as a given, that we're trying to achieve something and laying out the opportunities and challenges linked to that particular goal of expanding population coverage. Although I say opportunities and challenges, every challenge is an opportunity, and every opportunity often is a challenge. If I do get confused, you'll have to forgive me. So let me start with a few sort of what I would call stylized facts about where India is in terms of population coverage. And before I get on too far, let me give you a quick sense of the definition of population coverage I'm working with, population health coverage. Essentially, I mean, in one sentence, care that's of reasonable quality at affordable prices. That's it. In that sense, public systems that function well, like in Sri Lanka or Malaysia, do offer you almost complete population coverage. Whereas India, which at one point Adam Wagstaff referred to as having universal coverage at poor quality, obviously doesn't qualify for that role. Currently, as we see it, and this is probably what's driving much of India's concerns, is that more than 60% of India's health spending is out of pocket. There is, if you exclude the public sector services, at best 50% of population is covered through some sort of health insurance, pool funding, whether generous or not. Anything that you call insurance, that's what it is. There is a health system that's fragmented into public, private, and whatnot, none of which can be guaranteed to be of good quality, and the inefficiencies that are rife, which Jeff has pointed out again in his presentation. Now, India, of course, compares itself to China and other countries in the region, and let's just say that China has achieved, quote-unquote, universal coverage in some sense. It's gone through, unlike India, it actually had a fairly disruptive economic reform process that began in the late 70s. Literally, the entire existing health system fell apart, and then it sort of got stitched together. And so that 2011, almost 95% of the population was covered through some sort of hospital cover, and there were significant levels of outpatient coverage as well, although that varied by states and so forth. The more impressive cases of Thailand, which of course took a much longer period because they did invest in public sector activity for a long, long time before they launched on some sort of a health insurance scheme. But having decided on that in the early 2000s, Thailand did manage to achieve almost complete coverage of its population by the end of 2010. And generally Thailand is considered the role model in the region. So that's what India is sort of looking up to. In fact, I was in Delhi. Apart from improved economic growth, the other argument that I mentioned early on was the impact of coverage on financial protection against, risk protection against the financial risks of illness. And for that, again, there is good evidence. And here are three countries, Thailand, China, and India. The first two having seen substantial improvements in insurance coverage. The third one is still struggling with it. And we can see that certainly the gains in out-of-pocket payment reduction are much greater in China and in Thailand compared to India. And Thailand's going low every year. So certainly that's the case. Our own study in Andhra Pradesh, which was done in spite of the Secretary of Health not wanting it because they thought it might make Andhra Pradesh look bad, basically found that the Arogyasri scheme in Andhra Pradesh, this is the undivided Andhra before it broke up, and this is the very early part of the insurance program in the first couple of years. We basically found that there was a huge reduction in out-of-pocket payments for inpatient care, although not so much for outpatient care, not surprisingly because, of course, the Arogyasri scheme covered only hospital services. Of course, in India, given all its targeting issues, and of course the issue of the poor not being able to access benefits under many of these programs, we didn't find much of an improvement for SC/ST populations. So moving on from there, so what I've done here is simply saying, well, suppose you were committed to this goal of expanded population coverage, let's ask ourselves why we're setting on that road, at least from an economic argument basis, before we start worrying about the difficulties and challenges we face. So at least the economic case might still exist, even if the difficulties appear at first sight quite challenging. I haven't discussed the difficulties yet. So let's start with the opportunities. So what does the Ayushman Bharat initiative really mean to me? I should add that this is not really a paper. This is really my observations, thoughts that have arisen over the last 5 months. I've been in some dialogue process with a lot of stakeholders. And so this is something has emerged out of that dialogue and various exchanges. So what do I think of the Ayushman Bharat initiative? I think it sort of builds on a long history of public health insurance programs in India, beginning around the, well, I guess, the early 2000s. But for the first time, given the scale of the program, at least in theory, in a book sense, it's a signal of intent. And although the funding is not large, it's certainly larger than the RSBY program funding. So certainly one could say there is some funding down the route, and if the arguments of the RBI are anything to worry about, then perhaps there is some funding to be hijacked from the RBI as well. But I wouldn't know that. Such programs, once introduced, tend to be difficult to roll back. And now whether that's good or bad, I'm not sure. That's again back to Jeff's story about sunk cost versus non-sunk cost. But at least standing here, it seems to me that once difficult to roll back, there might very well be a movement afoot. And at least from the CEO of Ayushman Bharat, the statements that are here is a continuous process of improvement in the program. So one might expect improvements rather than simply, well, if it's a bad decision, it's a bad decision. There is a potential for learning from previous schemes. There are many schemes in India, as you know, the Chief Minister scheme in Tamil Nadu, there is the Maharashtra scheme, the Arogyasri, the Vajpayee scheme, and whatnot. So certainly, I think there is an opportunity here to build on learnings from previous programs. And I see that as an opportunity. And more importantly, I think for those of you who are knowledgeable about India, and most of you are, that India actually, we often talk about in health insurance, pools that help, promote equity, help protect the bad risks by funding money from the good risks. So the larger the pool typically tends to be better, but India, of course, has a plethora of risk funding pools for health. There is the RSPY program, there are state-level public insurance programs, then there is the ESIS, there is the CGHS, and so forth. So there is a whole range, there is a whole bunch of private insurers. There are also quasi-private, those public insurers that we have. So there is a very large number of pools going around, and so one might expect that the emergence of the Ayushman Bharat might very well create an impetus for bringing those different pools together. And certainly from the interviews I have read, although that's the only thing I have to go by, given the scheme is so new, there's a potential that in fact the scheme could well roll up many of the other state-level programs, and already there is talk of that. This is just a chart showing you a lot of fragmented pools. Of course, the biggest fragmentation is out-of-pocket spending, because then the pool is that of the household. So certainly, we're talking of very, very high levels of fragmentation. And it might happen that through tax financing, you're rolling some of this up. And of course, rolling up some of the other government programs. Of course, the multi-million-dollar question, where is the money going to be found? Now, those of you, again, who know, from what I've heard, most recently, about 12,000 crores were allocated to the Ayushman Bharat scheme. But apparently the Ayushman Bharat scheme has asked for another 40,000 crores. Now I don't know where the money is going to be found, but some of the estimates that I've heard, in terms of if they were to cover the full 500 million people to be covered, it might cost up to 1,50,000 crores, maybe even more. So where is the money to be found? Well, we can count on a lovely economic growth chart, which is sort of simply GDP. I mean, there was a lot of discussion on tax bases and so forth, and the GST, if it was successful and if GDP were to keep going up, and there were no financial crises, we could probably raise that money, except that there's this problem. If you look at China and India's history of financial allocations in the government to health, we find that India is basically flatlined over the last 15 years. Yes, it's moved from 0.9 to 1, and by the way, someone says 1.2 or 1.3 essentially is the divider, it's the number, the denominator, GDP, but market prices versus NDP and so forth. It doesn't really matter, the thing is basically flat, plus minus 0.1, 0.2. Contrast that with China, which was a little bit more than India in 2000, but it now exceeds 3% of GDP. So certainly, if you want to expand coverage, the lesson is you've got to find money from somewhere. this doesn't indicate much of fiscal capacity or fiscal will to allocate that money. Well, where might the money be found? In Australia, we have these discussions that, oh, money can be found in the following way. We can simply, because we have much fewer children, lots of elderly, we can, we'll reduce the education budget and enhance sort of allocations to health. Now, if you look at this chart here, look at the age structure for India. It's going to be another 30 years before our working age population really starts getting old. So I suspect there'll be a lot of pressure to allocate resources to the working age population and their human capital for a long, long period of time. I don't see it immediately obvious that we could shift large amounts of money based on this sort of argument. So what's left? Well, another possibility is simply hijack that 60% out-of-pocket spending somehow, some way, into allocations to the Ayushman Bharat and similar schemes. Only problem, who spends this money? This money is typically spent not by the poorest of the poor. They do spend some money, but the biggest chunks of money for out-of-pocket spending come from the top 3 quintiles. They are the ones spending money. So somehow we want them to buy into the Ayushman Bharat scheme and subsidize the others. Now in Thailand they tried it. In India, of course, one way to do it, if everybody was working in the formal sector, you could capture that money. You could simply tax people. But of course you can't identify people by their incomes because they're sitting in the informal sector, 90% of them. So in Thailand they gave up that idea. So they simply covered everybody based from taxes. Vietnam, by the way, couldn't do that because they also have a large informal sector. So what do they have? They have basically the middle income groups and the upper income groups simply don't buy into these public programs, basically, insurance programs. They simply stay out. So there's been big talk of subsidizing their participation. But if you subsidize, then the whole purpose of getting money in the form of out-of-pocket contribution that people would have otherwise spent goes away. And even if you did, people who join in from these groups would probably want a higher level of service. So then you no longer have the sort of universal common care. You have to start talking of different levels of care to be provided in order to attract that extra money. I do not know how feasible that is. But there is yet another angle to this. Suppose we can't attract these people. Perhaps the government has money to at least fund the people who are already intended to be covered in the Ayushman Bharat scheme. Perhaps the rest, at least even if we can't get their out-of-pocket money, perhaps we can get them into pooled funding of some kind, at least use the money more efficiently, and we can rely on the private health insurance sector to do that job. And well, here's how things go there. At some level, the private insurance sector is doing very well in that regard. The rate of growth of number of beneficiaries is 30% per year for the last several years. Quite large. The premium rates grew by, well, premium rates have also grown rapidly, I should add. 50% in real terms over a 5-year period, a 4-year period actually. This is, of course, taking account of inflation. But this is a largely unregulated sector because the IRDA is not specifically, the Insurance Regulatory Development Authority, is not particularly geared towards looking at issues of health insurance, except as a purely sort of an insurance entity. And they're concerned about the liquidity rules and so forth, but not so much about health insurance in particular. So what that has led to is a lot of, well, for want of a better term, hanky-panky in the insurance business. Very large loading fees, 30–40%, some of them would never survive in a well-regulated setup. Products that have a maximum limit. I mean, if you go to Australia and you ask for private health insurance cover, you don't get covered for the first $1,000, but then you get covered up to $3 million. Here it's the other way around. You get covered for the first 3 lakhs or whatever, and then you don't get covered at all. You basically get cleaned out. So in fact, all the net risk comes to you. It's not really an insurance product. It's basically, the insurance risk is borne by you. The insurance company gets your premium at some level. So there is that. So the products are essentially geared towards healthier groups and not really the elderly. And plus we have all these people getting bumped off when they get beyond 70. They can't even get access to private health insurance. So there is one risk one has to consider. If you are going to rely on the private health insurance sector, you have to deal with it in some way. Unfortunately, I was going to say regulation, but then in my other essay is Jeff who said, well, we don't have the capacity. Well, we'll worry about that later. But if we don't deal with it, I think the risk is that these elderly people, well, these working people who have insurance right now might get bumped off and become a fiscal liability 10–20 years from now. There is a real risk. They will be the elites, the most well-connected. Just like you have the implicit pension liabilities, you might have the implicit health insurance liabilities, except that you don't take the pension form. It's something worth thinking about. I'm not going to say it's going to happen, it's just a thought. That's for the financing side. But if you recall, I had mentioned up front that it's not just about financing, it's also about getting good quality care. And this is the last two slides, since I don't want to spend too much time on, because I was focused on financing. Financing is useful, but in fact, it only works if things are taken care of on the provision side. Experience Janani Surakshana Yojana, which basically was a conditional cash transfer, if you will, had led to increases in institutional deliveries and in use of public services.
Thank you for the presentation. I have a very specific question. It's like the Ayushman Bharat scheme, when you talk about it, especially when it comes to the insurance, which we understand is being delivered, what is your sense of view to the people, especially the clients? Like the clients are the beneficiaries, right? Now, if someone doesn't have a proper information about it, suppose he gets the premium and he doesn't have the proper information about it, what sort of provisions are being made? Specifically in terms of like what has happened in the Prime Minister Fasal Bima Yojana, the insurance which has been cut off from the bank accounts, the people itself are not being given those premiums, compensation out of it. So the institutions which will be used in this Ayushman Bharat scheme, what is your hunch in it, and what do you think can be a most effective way, because the scheme is launched. So now what is your hunch that to have an efficient system, to have a transparent system, what sort of institutions will need to be built in the existing scenario, given there are a lot of state schemes going on as well? Thank you.
Now what you say, there are a lot of challenges or a lot of risks associated with implementation of this. Number one is the funding, like 1,50,000 crores where to find it. And the institutional system. But I believe that institutions have been identified as to, and the methodology of making affordable medicines and also ensuring their quality. I don't think there is, my impression is that if it has succeeded in some countries, it should succeed in this country also. Now, the production of generic medicines has gone up substantially in India. The problem of corporate sector which are involved in production of medicine, they are the impediments. They are not willing to switch on to the generics. So the question that comes is, how do we say that the situation is such that it cannot be taken care of? I feel that small and medium scale pharmaceutical companies can make affordable medicines, provided there is an institutional setup to ensure quality control. This is the dilemma in which I am. I don't see any help coming to the healthcare. Most of the big hospitals are very allergic to Ayushman Bharat because the rates prescribed for the doctors or the hospitals are very low. But they are also hopeful that this is the start, and surely in course of time these rates would go up, so the hospitals will be more willing to accept or increase their turnover of medicines, of patients in due course of time. But you raised some doubts about insurance working. So what to understand from it? Is it going to fail the Ayushman scheme? Because this is entirely based on insurance.
So I think I'm not saying, or I didn't intend to say that the scheme will fail. I think schemes have a life of their own. What the purpose of this talk really was to highlight where some of the challenges, important challenges might be as we go along. And let's face up to them right now. And I'm sure it's not as if Mr. Indu Bhushan and the powers that be in the Prime Minister's office haven't thought about these issues. But for the general public, I think it's useful to understand what some of the challenges might be and how, how one might address them at some point, or how one should begin thinking about addressing them. So, but I can't say whether it will succeed or fail offhand. But I don't see why it will just go out of business. It will just remain. Like RSBY, for example. I mean, RSBY, I don't think we gave sufficient thought to it, but look what happened. They began slowly taking more and more money out of it. Essentially, it was emasculated. 1,000 crores was the amount spent in the last year of RSBY. So I can't say offhand, but I'm not going to say it's going to fail. That was never my intention. As far as your question regarding institutions, I do not know what's going on in the minds of the Ayushman Bharat people. I mean, this is after, they have entire committees in place to address. I mean, that's part of the comment I made when I said that there's learnings to be had from previous insurance programs, where in fact, one of the big concerns with both, even Arogyasri was that poor people weren't quite aware of the benefits or even the enrollment. So in that sense, I think Ayushman Bharat has learned, and one example being that you are automatically considered enrolled without, if you're eligible, without having to actually have a registration card. So that's certainly is an improvement in terms of what the previous programs have been about. But in terms of more detail about exactly what they plan to do to address challenges in the program, I wouldn't know, not at this point. I think you'll see this being rolled out over several years. I mean, look, as I see it, this is a multi-year, perhaps even a decade-long exercise. So I think it's just been a couple of months since it started.
If Ayushman Bharat had to learn from international experience,
yes,
which country would be the best? Since we have done in so many countries.
Well, you have Thailand around the corner.
Okay.
But Thailand is different in the sense that they invested heavily in their public sector for 25 years before they got around to introducing their insurance program. I hate to say it, but actually Australia might be a good example because they have a strong private sector, private insurance which has run amok over the last 2 decades, 3 decades. So there might be something to be learned from Australia.
But Australia, insurance is also private sector. It's not.
No, well, there is public insurance, but there is also private insurance. And of course, you could have other, I don't know if you learn China, but I think China and Thailand also gave those examples are very different countries than India.
I know that.
Extremely strong central governments, and both had long investments in public, at least certainly Thailand. But I would say of the countries in the region, I would say Australia comes the closest. Perhaps Vietnam, but Vietnam is not even there yet.